I want to talk to you about something that's affecting a significant number of women that I work with who are doing IUI cycles, timed intercourse with ovulation medication, or preparing for IVF. You've been given Clomid or Letrozole. Your doctor prescribed it to stimulate ovulation or to recruit more follicles or to improve your response. And maybe it's working in the sense that you're ovulating. Your follicles are growing, your timing is on, but you're still not getting pregnant. And nobody has checked your uterine lining. Here's what I want you to understand today. Both Clomid and Letrozole can thin the uterine lining. This is a known documented side effect, particularly with Clomid, which has anti-estrogenic effects that directly impact endometrial development. And a thin lining, even with a healthy egg, even with good sperm, even with ovulation timed perfectly, significantly reduces your chances of implantation. So, in other words, the medication you were given to help you get pregnant may be creating a barrier to implantation that nobody told you about. I see this consistently. Women who have been on multiple IUI cycles with Clomid, getting the right stimulation, ovulating on schedule, and still, month after month, it doesn't work. And when we actually look at the lining, we find it's too thin. And the conversation about why it's thin and what to do about it has simply just never happened. So today, we're going to have that conversation. Hi, I'm Dr. Marc Sklar, the Fertility Expert. And this is one of those videos that I genuinely hope reaches the right woman at exactly the right time. Before we dive in, if you want to take action right now, I've created a free guide called The Proven 6 Ways to Improve Egg Quality in 90 Days. Grab that in the description below. Now let's get into this video. Let me give you the foundational biology first, because I think it's important for you to actually understand what these medications are doing and not just that they were prescribed for you. Clomid, the generic name for clomiphene citrate, works by blocking estrogen receptors in the hypothalamus. Your brain thinks estrogen is low, so it sends a stronger signal to the pituitary to release more FSH. More FSH means more follicle recruitment, stronger ovulation, and in some cases, multiple follicles developing at one time. Here's the problem. Estrogen doesn't just affect the hypothalamus. It also stimulates the uterine lining, the endometrium, to grow and thicken in preparation for implantation. And when Clomid blocks estrogen receptors at the level of the uterus, which it does as a side effect, the endometrium doesn't get the signal to grow properly. It can stay thin even in a cycle where ovulation happened beautifully. In clinical practice, a uterine lining of 7 millimeters or thicker at ovulation is considered the minimum for implantation. Ideally, we want 8 millimeters or above with a trilaminar pattern on ultrasound. Under 7 millimeters, and especially under 6, implantation rates drop off significantly. Now, Letrozole, which works differently by suppressing estrogen production rather than blocking its receptors, is generally considered to have a less severe impact on the lining. It's one of the reasons Letrozole has largely replaced Clomid as the first-line ovulation induction agent in PMOS, particularly for IUI cycles. The line-sparing effect of Letrozole is a genuine clinical advantage over Clomid. But, and this is something I want to flag, Letrozole is not completely free of this issue. In some women, particularly those who are estrogen sensitive or who have underlying hormonal imbalances, Letrozole can also result in insufficient lining development. The mechanism is different from Clomid, but the outcome can be similar. And in high doses, or in combination protocols, the risk actually increases. Kimberly, one of the members in my program, went through Clomid at multiple doses, then Letrozole, and Clomid combined. She had ectopic pregnancies. She had chemical pregnancies. She had implantation failure. And throughout all of this, her uterine lining had never been formally assessed and addressed. That's not unusual, and it's a gap that matters enormously. Let me be specific about what happens when the lining is thin, because I think this will help you understand why this is not a minor issue. Your uterine lining, the endometrium, is the landing pad for a fertilized embryo. For implantation to succeed, the endometrium needs to be thick enough, minimum 7 millimeters, ideally thicker, adequately vascularized. There needs to be blood flow reaching the surface layers, and properly receptive, which means that the right cytokine environment, the right progesterone response, and the right window of implantation. When the lining is thin, several things happen simultaneously. First, there's less physical space for the embryo to implant. The endometrium simply doesn't offer as many cells with which the embryo can begin the adhesion and invasion process. It needs to burrow in. Second, thin linings are often associated with reduced blood flow. And reduced blood flow means reduced delivery of the progesterone, the nutrients and immune signals that early implantation requires. Third, and this is less discussed, a thin lining often signals a broader hormonal imbalance. If your estrogen signal isn't reaching the uterus properly, the same estrogen deficiency may be affecting your cervical mucus, your progesterone production in the luteal phase, and your overall implantation window. So thin lining is not just a number on an ultrasound report. It is a window into the hormonal environment of your whole cycle. I want you to ask for an ultrasound to check your lining at or near ovulation on any medicated cycle. This should be standard of care. In too many cases, it just isn't. Now, what can you actually do? Let me give you practical strategies starting with the natural approaches. The first is maximizing dietary estrogen support in the follicular phase. This doesn't mean taking estrogen supplements. It means eating foods that support your body's natural estrogen production and activity during the first half of your cycle. Flax seeds, which contain phytoestrogens that support healthy estrogen metabolism. Cooked tomatoes. Fermented soy in moderate amounts, and a diet rich in colorful vegetables that support liver detox and estrogen clearance. Equally important, supporting liver function. Your liver is responsible for processing both your endogenous estrogen and any environmental estrogens like xenoestrogens from plastics or pesticides. If the liver isn't clearing excess estrogens properly, they get reactivated, contributing to dominance patterns. But if it's not processing them efficiently at all, your usable estrogen may be lower than it needs to be. Liver supportive practices like eating cruciferous vegetables, adequate B vitamins, avoiding alcohol completely, they matter right here for this reason. The second natural approach is addressing the circulation component. Thin linings are often associated with reduced uterine blood flow. Practices that improve circulation to the uterus are vigorous walking in the follicular phase. Acupuncture, there's good evidence for this specifically in thin lining cases. And castral packs on the lower abdomen in the follicular phase, but you've got to stop after ovulation. Third, vitamin E. There is specific research showing that vitamin E supplementation can improve endometrial thickness in women with thin linings, particularly in medicated cycles. So you want 400 to 800 IUs of mixed tocopherols in the follicular phase. This is something that I often recommend. And fourth, L-arginine. This amino acid improves vascular, smooth muscle relaxation and increases blood flow. It has been studied in the context of thin lining and IVF outcomes with some promising results. It's not a guarantee, but it's a reasonable addition in a thin lining protocol. Beyond the natural strategies, there are medical interventions worth knowing about. First is estrogen supplementation in medicated cycles. If your lining is consistently thin on Clomid or Letrozole, adding estrogen, typically in the form of estradiol patches or oral estrogen, in the follicular phase can counteract the anti-estrogenic effects on the endometrium. This is a well-established approach in reproductive medicine, but it is not universally offered or discussed. So make sure you ask about it if this is happening to you. Second, switching from Clomid to Letrozole if you haven't already. As I mentioned previously, letrozole has a less severe impact on the lining. For women whose cycles show thin lining specifically on Clomid, this switch is often the simplest and most effective first step. Third, the combination mini-stim protocol. Instead of high-dose oral medication alone, some clinics use a lower dose of letrozole combined with low-dose injectable gonadotropins. This approach reduces the thin lining side effect by lowering the dose of the overall medication while still achieving adequate follicular development. It is a more tailored approach and worth exploring if standard protocols just aren't working. Number 4, consider the timing and duration of medication. In some cases, adjusting when in the cycle the medication is started or shortening the duration can reduce the cumulative anti-estrogenic effect on the endometrium. And fifth, if the lining problem is severe, persistent, and unresponsive to all the things I mentioned, it's worth evaluating for deeper structural issues. Uterine pathologies such as submucosal fibroids, endometrial polyps, or intrauterine adhesions like in Asherman syndrome can all contribute to consistently thin or abnormal lining patterns. These require imaging, typically a saline infusion sonogram or hysteroscopy, to identify it. This is where the assess phase inside the HOPE program becomes critical. We are not just looking at the number on the ultrasound. We are looking at the system that is producing it, the hormonal cascades, the liver function, the gut estrogen axis, the vascular health of the uterus, and building a protocol that addresses the actual drivers causing the problem. I want to end the clinical section with this point because I think it's important. There comes a point where continuing the same medication cycle after cycle without seeing a meaningful change in the lining is not a strategy. It's inertia. It's the hamster wheel. If you've had 3 or more medicated IUI cycles with consistently thin lining, inadequate implantation windows, or no pregnancy, that is data. It is your body telling you that this protocol is not right for you. It's just not the right fit. So what comes next really depends on the full clinical picture. For some women, the right next step is a natural or modified natural FET cycle, using your body's own hormonal cycle as the environment for transfer rather than a medication-suppressed one. For others, it's a more thorough investigation of the underlying reasons the lining isn't responding. Gut health, thyroid, estrogen metabolism, through possibly a Dutch panel. For others still, particularly those with PMOS who are anovulatory, the goal isn't to abandon ovulation induction, but to find the version of it that works for their or your system specifically. That might be letrozole with estrogen added back. That might be a mini stim protocol. That might be addressing the root cause of the anovulation, insulin resistance, HPA dysregulation, thyroid, so that ovulation can happen more naturally with less pharmaceutical support. The through line in all of this is the same. Your body is giving you information, and that information deserves a response that goes deeper than adding another cycle of the same medication. If you're in a cycle or preparing for one, and you've been on ovulation medications without a clear conversation about your lining, I want to invite you to have that conversation with my team. A fertility assessment discovery call is where we look at your whole picture, your medications, your history, your labs, your cycle patterns, and help you understand what's actually going on and what to do about it. I'm going to leave that link in the description below. If you're on Clomid or Letrozole and you haven't had your uterine lining assessed at ovulation, please advocate for that at your next appointment. It's not a complicated request. It's a 5-minute addition to your monitoring appointment, and it could explain a great deal about what's been going on. If your lining is consistently thin, that is not something to accept as an unavoidable side effect of treatment. It is something to address. There are natural strategies, dietary approaches, supplementation options, and medication alternatives that can make a real difference in your outcome. And if you've been cycling month after month without a meaningful conversation about why it isn't working, the conversation I've had with you in this video is the one that needs to happen with your care team. That shift starts with information, and it continues with the right support. And if you're ready to stop guessing about your lining, your medications, and your protocol, apply for a fertility assessment discovery call with my team. For your next video, I've done one on why regular periods don't guarantee good fertility and the specific things that can go wrong even when your cycle looks normal. That one is going to be very relevant if today's video spoke to you. I'm going to leave that right here. Until then, stay fertile and stay hopeful.